a success with over 21.
Hello, everyone. Welcome back to another day of a review session. How's everyone doing? Let me just take a look real quick into my setup here. I'm not quite sure what's going on with this stream. I hope that you can hear me. I'm not quite sure with the thumbnail right there. It looks like it's the second session's thumbnail, but we'll proceed with our review this 4th of July. How's everyone doing? For those who are living here in Asia or in the US, I hope you have a great evening. All right, let's get started. All righty. Now, we are on the 42nd day of our review session, and for those who are new in this channel, we are actually doing the 90-day free NCLEX review sessions, and we'll be tackling so many nursing topics, and we are discussing the medical surgical nursing concepts at the moment. And we are also inviting you to enroll to our comprehensive NCLEX review course at Stanco's NCLEX Coaching, and where you can access about 3,000 NCLEX-style questions and 10 hours of animated videos. And also we are wanting you to check out our website so that you will know more about us. And if you need to take a look, please check the description box below, and we really welcome your thoughts, your comments, and we'll be happy to answer your questions as well. And we encourage you to like and subscribe, and also to share this video to your friends who are reviewing for the NCLEX. For today, we will be talking about the different types of anemia, basically the macrocytic and microcytic type of anemia. And so let's get started right now. Okay, now we'll be talking about the vitamin B12 deficiency, which basically is a condition wherein there is an inadequate amount of the vitamin B12 in the body. Okay, please take note. There is a deficiency in the vitamin B12 in the body. And we will talk about a little bit of an overview on the function of the vitamin B12. And this is known as the cobalamin, which is going to play a role in so many processes. And the cobalamin basically will aid in the production of the red blood cells. Okay, function of vitamin B12. We refer to that one as the cobalamin, and it will help in the production of red blood cells and also the function of the nervous system, CNS function. Now, when we are going to tackle the vitamin B12 here specifically, it is going to be a cofactor. It is going to be helpful in the production of the red blood cells, as I have said. It is going to help convert the homocysteine into methionine, okay? So with the red blood cell production, the vitamin B12 will help convert the homocysteine to methionine. And this is a very important reaction in order for the synthesis of the DNA and also the maturation of the red blood cells. So this conversion is very important for the DNA synthesis and also the maturation of the red blood cells. So please take note of that. So if there is a lack of the vitamin B12, then how do you expect about the maturation of the red blood cells or the CNS function if there is such a deficiency? And so this is going to really affect the overall function of our patient. Now, another is the function of the vitamin B12, which basically will help the conversion of the methylmalonyl coenzyme. Okay, so this is the methyl, another tongue twister, methylmalonyl coenzyme 2-succinyl CoA. So this is another process that would be essential in maintaining the integrity of the myelin sheaths in the nerve cells. Again, another function of the vitamin B12 is to help convert the methylmalonyl CoA to succinyl CoA, which will be helpful in maintaining the integrity of the myelin sheaths in the nerve cell. And so if there is going to be a deficiency in vitamin B12, what would you expect if there is deficiency in B12? Well, the patient will now manifest so many neurological manifestations, neuro signs and symptoms, and they're gonna develop those peripheral neuropathy. Their cognition will be impaired, and some patients will develop psychiatric symptoms as well. So again, that's peripheral neuropathy. There will be cognitive impairment and also psychiatric manifestations. Now let's talk about the different dietary sources of the vitamin B12. So what are those sources? Well, they can be found in, let's say, foods like meat, could be fish, eggs, dairy products. So those are the rich sources of the vitamin B12. Fish, eggs, also dairy products. Okay, and liver would be another great source, and also meat. Okay, so when we are talking about like the other sources, let's say plant-based foods, they do not naturally contain the vitamin B12 unless they are fortified. So please take note of that. Plant-based food sources are not gonna be reliable sources of the vitamin B12. Not reliable sources of B12. And so they need to be fortified in order to be very efficient in supplying the body of the vitamin B12. Now, let's talk about the absorption of the vitamin B12. When we are taking in the vitamin B12, of course, this will take place in the terminal ileum of the small intestine. Okay, so this is where the process can take place, in the terminal ileum. And of course, this is in the small intestine. So guys, if there is going to be a problem, let's say a disease, maybe Crohn's disease or inflammatory bowel disease or any kind of malabsorption syndrome in this section of the small bowel, then there is going to be poor absorption of that vitamin B12. And again, it will lead to that deficiency. Now, take note, guys, that in order for the vitamin B12 to be utilized, it has to be bound to the intrinsic factor. Okay, so take note of this words, intrinsic factor. This is going to be that substance that will be helpful in the absorption of the vitamin B12. And this is it's a glycoprotein, rather, produced by the gastric of the parietal cells. So this is produced by the parietal cells of the stomach. And this is going to be important, really, in the absorption. So please don't forget about the intrinsic factor. And once the vitamin B12 is bound to this intrinsic factor, this can now be absorbed into the bloodstream through the different receptors in the ileal mucosa. Again, the vitamin B12 will be aided, with a intrinsic factor. This will help in the absorption through the receptors in the intestine, the small bowel, specifically the ileum, and this will now be absorbed into the bloodstream. Now, talking about the storage here, where will the vitamin B12 stored in the body? Well, the primary storage will be the liver. This is the primary site of storage. Okay. So the methylcobalamin and also the adenosylcobalamin forms will be stored here for about 3 to 5 years. Okay, so this can actually sustain the person for several years. Imagine that, about 3 to 5 years storage in the liver. Okay, so this is our primary site of storage. Now take note, guys, that when we are talking about the vitamin B12 deficiency, there are so many causes. And one of those is the pernicious anemia. So what is this pernicious anemia? This is the autoimmune disorder that can destroy the parietal cells that is supposed to produce the intrinsic factor. And this is a predominant problem in the Western countries, and also the most significant cause of vitamin B12 deficiency. Okay. Top cause of vitamin B12 deficiency, that is the pernicious anemia. Another is the gastrectomy. Well, the gastrectomy is basically the surgical removal of part of the stomach, or maybe all of the stomach can be removed, right? And so this can also lead to the deficiency of the intrinsic factor. So please take note of that. Leads to intrinsic factor deficiency. And also, when people are, like, let's say, strictly vegetarian, they can also suffer from the vitamin B12, especially for those excluding the animal-derived foods. And so they're going to be expected to have the vitamin B12 deficiency as well. Another is a vegetarian diet with exclusion, of course, with the animal products. Chronic alcoholism is another one. alcoholism, because of course this can lead to the poor dietary intake as well, and it can also impair the absorption of the vitamin B12. Now, another problem that can lead to the vitamin B12 deficiencies will be those conditions like Crohn's disease, and also possibly the surgical resection of the terminal ileum. So these are things that can lead to the vitamin B12 deficiency as well. Again, that's the surgical resection of the terminal ileum. Hello, everyone. For those who just came into the class. And another is the Crohn's disease, wherein it can lead to the malabsorption. Okay, it will not allow the absorption of those nutrients, including the vitamin B12. Crohn's disease, aside from the surgical resection. And there's also going to be what we call as competitive absorption. So what do you think is involved here? Well, when we're talking about the competitive absorption, this pertains to the presence of infectious agents. Let's say microorganisms. We have that as the Diphyllobothrium latum, or known as the fish tapeworm. Okay, so this can compete with the absorption of the vitamin B12. So this is an infestation of that parasite. Okay, this is what we call as the Diphyllobothrium latum. Okay, now another problem that can lead to the vitamin B12 deficiency is that bowel loop syndrome. Basically, this is going to be another factor which can basically lead to the overgrowth of the bacteria in the intestine. Okay, bacterial overgrowth in the intestine. So this can compete with the absorption, and with this kind of vitamin B12 deficiency, we refer this as the megaloblastic anemia, and this is going to it's very important for us to distinguish between the folate and the vitamin B12 deficiency before we're going to have to start the treatment. I repeat, before we're going to have to treat the patient for the vitamin B12 deficiency, we need to distinguish first between the folate and the vitamin B12 deficiency. So we want to make sure that we have carried out the diagnostic procedures first before we're going to start treating the patient. Because if we are just going to start giving the patient vitamin B9 to a patient with a vitamin B12 deficiency, this can potentially mask the manifestations. And so we're not going to do that. Okay. So let's go over into our next section of the topic here, which are the assessment findings. And top of the list here is the sore tongue, called as the stomatitis or the glossitis, the inflammation of the tongue and the mouth. So these are the most common assessment findings in a patient with a vitamin B12. So what are these two? Well, of course, there is going to be the inflammation of the tongue and soreness, of course. And this is occurring because of the different changes in the epithelial tissue of the tongue. Now, another assessment finding here would be neuropsychiatric changes and dementia. So what you will notice in this patient will be a significant memory loss. Please take note of that. Significant memory loss will be a top nursing assessment, especially for the adult person. And here, they're probably going to exhibit many cognitive changes. They probably will have some kind of confusion, disorientation, and this can progress into more severe forms of the dementia if this is untreated. Okay. All right. Hello, everyone. For those who came in to the classroom just a few minutes ago, welcome. But let me go ahead and check one more time in our streaming here. I hope that everything is running okay. Yeah, because I'm seeing that we are in a different thumbnail. I'm not quite sure what happened to that, but as long as It's streaming okay? I'm fine with it. Yeah. All right. So the thumbnail will be dealt with accordingly later on. Now, we're going to talk about other manifestations such as neuropathy. So what is this? This is what we call as the hallmark feature that will help us distinguish between vitamin B12 deficiency and vitamin B9 deficiency. This is the hallmark of vitamin B12 deficiency. So this is what's going to set it apart from the vitamin B9, all right? Because when there is vitamin B9 deficiency or folate deficiency, they will not have the neurological manifestation, okay? Let me write this down here. In vitamin B9 deficiency, there's no neurological manifestations. But here in the vitamin B12 deficiency, this is the hallmark. This is what's going to set it apart from the other anemias, okay? There is going to be that neuropathy, and also there are some other manifestations aside from that one. Other neurological manifestations, I should say. And so what are these things? Well, the person will suffer from numbness. Their sensation will be altered. There's going to be tingling sensation. And also burning sensation in the extremities. All right, neuropathy, guys, please don't forget that one. And other neurological manifestation. And in some cases, they will also lose that kind of sense of position. This is what we call as lack of proprioception. Lack of proprioception. Again, this means that there is a loss of position change, or sense rather, and they also will have that vibratory sensation loss, okay? Loss of vibratory sensation. So our patient will definitely have some kind of deficit as far as like with their peripheral distal extremities, of course. They will not be able to really tell, hey, something is not right with my surrounding right now. So their sense of touch is greatly affected here. And because of the nerve damage that has already set in. Now, another neurological manifestations in vitamin B12 deficiency would be the degeneration of the spinal cord. And this is really going to cause a lot of problems here, especially if it's affecting the dorsal and lateral columns, wherein the person will really have difficulty in sensing the position of their limbs. And so the person will end up with uncoordinated movement. So they will have the ataxia. Their gait will be affected. They're going to be prone to falling. Gait problems. So that would be gait problem, especially if the affected part of the spinal cord is in the dorsal and the lateral columns. So gait problem. And also when there is an effect into the motor neurons, upper motor neurons rather, their deep tendon reflexes will also be increased, okay? Increasing DTRs. There's going to be some spasticity of the muscles and also some weakness, or could be the presence of the Babinski's reflex. Okay, let me add to that one. There's going to be presence or positive Babinski's in the adult, on top of the increasing deep tendon reflexes. And of course, these are going to indicate the upper motor neuron dysfunction. So don't forget about these manifestations. Again, this is exclusive to the vitamin B12 deficiency, not going to be found in a vitamin B9 deficiency. So this is the hallmark. Now, let me clear my whiteboard right now. I guess we're going to have to move into another slide. Now, let's talk about the different diagnostic tests that will help diagnose the vitamin B12 deficiency. And one of those would be the peripheral blood smear. And so what is this? This is going to show us the kind of anemia the patient is having. So this will reveal megaloblastic anemia. Okay. And this is what we refer to as the macrocytic anemia. So the red blood cells are actually huge, larger than normal, but they have abnormal shape. Okay, they are immature red blood cells. And the reason because of the bone marrow is producing these abnormally large red blood cells. And they are lacking in the nutrients, okay? They lack nutrients, so they cannot really function like the mature red blood cells. And this is not really considered a serious illness. However, if this is left untreated, then this can cause major issues. Now, when we are looking into the microscope with the peripheral smear, this is what's going to look like, right? Let me get rid of that. And so there will be that large red blood cells, okay? And there's that kind of what we call as the teardrop cell. And there is also the presence of the hypersegmented neutrophils, wherein their lobes are kind of like more, they will actually contain more lobes than usual. And again, the red blood cells here will look larger compared to a normal red blood cell. Okay, so that's why they're called as a megaloblastic type of anemia. Please don't forget that. Megaloblastic type of anemia. Now, when we are also going to take a look into the serum level of the vitamin B12, well, it will be lower. And so the level here will be less than 200 picograms per ml. So anything below 200 will be considered as having vitamin B12 deficiency. And also, if we are looking into the methylmalonic acid and the homocysteine levels, let me erase this first. When we're looking into that lab value, then it can also reveal some elevation of the methylmalonic acid. There is elevated value of the methylmalonic acid, and which is going to be above 0.4 micromoles per liter. So that would be our indicator that there is a vitamin B12 deficiency. And also the homocysteine levels will be above 15 micromoles, greater than micromoles per liter. And again, it will suggest that there is vitamin B12 deficiency. Another diagnostic test that will be helpful is the checking of the intrinsic factor antibodies. So this will test in order to diagnose pernicious anemia. To check pernicious anemia. And this will help us identify that the immune system is actually attacking the intrinsic factor, which is supposedly the protein that is needed for the vitamin B12 absorption in the intestine. But the antibodies are actually attacking the intrinsic factor. So it's no longer going to be helpful in the absorption of the vitamin B12. Now, another diagnostic test that you probably have known way before is the Schilling's test. So what is this? This is a very old diagnostic test for the vitamin B12 deficiency, and it's now most medical providers are not using this one anymore, and most hospitals don't have the supplies to use this kind of diagnostic. As what I have seen in most literature, it's not as popular compared in the past. Okay, so today we're not going to see a lot of the Schilling testing anymore, but it's still beneficial. But again, it's not as popular to the newer testing. Okay, now if you recall about the Schilling test, so if it comes out in the exam, you're probably going to be asked how this procedure is done. And so with this Schilling's test, what they're going to do to the patient is to administer the radioactive B12. Okay, radioactive, I'm not quite sure with my handwriting today. All right, radioactive vitamin B12 administration. Radioactive B12 will be administered to the patient. And then after that, the patient will also take a small oral dose of the radioactive vitamin B12. So this is going to happen after that. Okay. And then they will check the patient's urine 24 hours after. Urine collection. And this is to check for the vitamin B12 absorption. Now, there's also what we call a stage 2 part of the Schilling's test. So what is involved in stage 2? Well, the intrinsic factor will be administered here. And so if there is poor absorption of the intrinsic factor, then they're going to receive the vitamin B12 with the intrinsic factor. And then another 24-hour urine collection will be done in order to measure how the intrinsic factor is absorbed in the body. And so the urine sample will be analyzed and it will be interpreted, and it will compare the vitamin B12 absorption with and without the intrinsic factor. And so the normal result here will show an increased B12 absorption, of course, with the intrinsic factor, which will signify that there is normal absorption. However, it will show an abnormal result if there is little or no improvement in the absorption. Okay, so that's about the Schilling's test. Now let's move forward into the treatment, guys, for the vitamin B12 deficiency. So there are different forms here. So our patient will have so many options, but in the standard therapy, especially if there is severe deficiency of the vitamin B12, then they're going to be offered the intramuscular route, or it could be the subcutaneous route. So if we're talking about the intramuscular injection of the vitamin B12, their initial treatment will be about 1,000 micrograms daily. And also it can be given as every other day for 1 to 2 weeks. So this would be the initial treatment of the vitamin B12 deficiency. If they're getting the IM, so during the initial phase, they're going to get the 1,000 micrograms per day and will be given every day for 1 to 2 weeks, or let's say every other day. Now for the maintenance therapy, the patient will be getting the 1,000 micrograms, and this is going to be every 1 to 3 months. 1 to 3 months. Every 1 to 3 months. Take note of that sign, Q. All right. The patient here, when they are getting the intramuscular route, of course, this would really require the person to be compliant with the visits in order that there will be maintenance of that level in order to achieve that desired level. Okay. Now, when we are talking about another route here, which is going to be the subcutaneous, let me erase this. So another route is the subcutaneous. And the patient here will, of course, receive a different dosing or maybe similar dosing. They can get the 1,000 micrograms as well. And this is going to be given the same frequency with the intramuscular as well. Now, talking about the sublingual, and this is also going to be an alternative for those patients that will not be able to tolerate the intramuscular and the subcutaneous. Yes, we do have the sublingual route, which can also allow better absorption of the vitamin B12, because of course, if this is given sublingually, the blood vessels in that area will actually help in absorbing the vitamin itself, and it will directly be distributed into the bloodstream without going into the liver. Okay, so this is another alternative for this patient with a vitamin B12. Again, sublingual route is an alternative, and this is going to be useful for those patients that may have chronic type of vitamin B12 deficiency as well. And this is going to be taken daily or maybe a few times per week. And so the dosing schedule for the sublingual will vary from about 1,000 micrograms to about 5,000 micrograms. And we know, of course, that the absorption will be a whole lot better when the patient is given the IM or let's say subcutaneous. But sublingual, there's going to be a need for a higher dose because, of course, it's not going to be absorbed better compared to the other two. Now, let's talk about the oral dose of the vitamin B12. And this is going to be used for those patients that may have a mild form of the deficiency. And the range of dose will be about 1,000 micrograms to about 2,000 micrograms per day. Let me rewrite that. 1,000 micrograms to 2,000 micrograms per day. And again, this is indicated for those patients that have a milder form of the vitamin B12 deficiency. Now, let's talk about the folate deficiency, which is actually the vitamin B9 deficiency. So what is this? Well, let's talk first about the role of the vitamin B9, guys. Or specifically the folate or the folic acid. Well, the folic acid basically is going to be helpful in the making or the production of the DNA, which is basically the genetic material in our cells. And, excuse me, it is also important in the periods of rapid cell division, especially during pregnancy and infancy. So again, this is going to be helpful during rapid cell division in states wherein there is pregnancy or during infancy. Now, let's talk about the source of the folate here. It is going to be taken from some food items here, especially like vegetables, spinach, broccoli, maybe fortified foods that has folic acid in it. And so again, let's name them. Spinach is one, broccoli is another. So they are rich in vitamin B9. And also we can get the fortified forms of other food items. And of course, there's also that synthetic type of folate that is going to be found in some cereals and bread. Now let's talk about the storing of the folic or the folic acid rather. And so the vitamin B9 basically cannot be stored longer, or it cannot be stored in larger amounts. Okay, and so if the body is not taking that dietary requirement for a few months, then the patient will lead into the vitamin B9 deficiency. So it can be easily depleted. It's not stored in the body like the vitamin B12. Okay, so again, the vitamin B9 is easily depleted if the person will not be taking a lot of the vitamin B9 in their diet. And so automatically they're going to manifest those signs and symptoms of B9 deficiency. Now let's talk about the causes of deficiency here. What do you think are the causes? We have several, guys. And of course, poor diet is one thing. If the person is not eating enough folate-rich foods, this can really lead to that deficiency, especially if they're gonna be doing a lot of tea, maybe intake of coffee, or let's say they're just doing the tea and toast kind of diet. Or let's say if they're alcoholic as well, they're going to be prone to developing vitamin B9 deficiency. For those patients that may be taking some medications, let's say antibiotics, so they can be prone to developing that as well. Whoops, what happened to my pen? Hello, everyone. For those who just came into the classroom, welcome back. I hope that you had a great July 4th today. All right, so for those medications, we are talking about the antibiotics. And for those patients that may be taking the methotrexate, especially in the treatment of CA or let's say rheumatoid arthritis. And also for those taking the anticonvulsants like phenytoin. So these are common medications that can lead to vitamin B9 deficiency. Antibiotics, methotrexate, anticonvulsants, specifically phenytoin. Now, in some cases wherein there is an increasing need for the vitamin B9, this can also deplete the body of the vitamin B9 itself. So if the person is getting pregnant, of course, with a baby inside, this will really require the mother to have more intake of the vitamin B9. And so if they're not taking enough sources, then they're going to end up with the B9 deficiency. Another cause will be the digestive issues. Similar to the vitamin B12, if let's say they have some kind of malabsorption syndrome, maybe they have celiac disease. Okay, that's one condition that can cause malabsorption. Okay, so this is the problem in the gluten, right? Found in wheat, barley, and rye. And so the celiac disease can actually destroy the lining of the small intestine. Okay, so the celiac disease. Okay, all right. Celiac disease, sorry. This will destroy the lining of the small intestine. And this will now impair the absorption of the nutrients, including the folate. Now, another problem that is all about the digestive problem here is the IBD, inflammatory bowel disease, okay? Aside from celiac disease, so it will include the Crohn's disease, the ulcerative colitis. These diseases are actually going to cause chronic inflammation and damage to the digestive tract, okay? Chronic inflammation and damage of the bowel. Or the intestine. So again, if there is inflammation in the intestine, then this can also impair the absorption of the vitamin B9. Now, there's also what we call a short bowel syndrome, which is basically going to occur whenever there is a surgical procedure, there is resection because of maybe there is a disease or there is a damage already. And so it needed to be removed, right? And so this will reduce the surface area available for the absorption of that nutrient. And so this can lead to the vitamin B9 deficiency as well. And for those people that may have some form of pancreatic insufficiency, so what does that mean? This is going to reduce the production of the enzymes that will be needed to digest the food properly. And so if there is a lack of the enzyme, then there is going to be less absorption of the vitamin B9 as well, and along with the other vitamins and minerals. Another is the dialysis. There's also the, bariatric surgery. Okay. Bariatric surgery for those morbidly obese people that would require this surgical procedure, or let's say the sleeve gastrectomy. This can actually alter the anatomy of the digestive system, and it will also reduce the surface area available for the absorption of vitamin B9. Okay, so please take note of the bariatric surgery as well. So they're gonna need lifelong replacement of the vitamin B9. Another is chronic alcoholism. As we know that alcoholism will also impair the absorption, and it can also alter the lining of the intestines. And again, our B9 absorption is going to be affected. There's also the gastric bypass surgery wherein, again, it will alter the absorption of the same vitamin. Now let's talk about the clinical features of vitamin B9 deficiency. Well, they're going to have some similarities with the vitamin B12. However, like I've said earlier, in vitamin B9 deficiency, there will be no neuro manifestations. Okay, that's what I said earlier. All right, let's talk about the no neurological symptoms. Why? Because the folate deficiency doesn't typically affect the nervous system. So again, the patient will not be showing any signs of those numbness. There will be no tingling sensations and no problems in their balance. So none of those. But we're also going to talk about the diagnosis here. So what would be, the cognitive impact rather. We still need to consider the folate deficiency, especially in the older adults. We need to make sure that we are screening them properly for possibilities of memory loss or maybe dementia, because it can also lead to some cognitive changes. Okay, so this is that part wherein it can lead to some memory changes. But as far as like the other neurological manifestations like peripheral neuropathy, it will not lead to those kind of neurosymptoms. Now, let's talk about the diagnosis here of the folate deficiency. One would be the testing of the blood through the peripheral blood smear. So this will help show the size of the red blood cells. And again, this is another type of megaloblastic anemia. Large red blood cells that are immature. They're not going to be able to function properly compared to a normal red blood cell. They are bigger than usual, but very immature. Now we're also going to tackle on the serum folate level. This is very important in order for us to identify the level of this vitamin. And in the adult, our normal range for the serum folate is about 2.7 to about 17.0 nanograms per ml. So this is the usual range for the serum folate in the adults, 2.7 to 17 nanograms per ml. And on top of that, we're also going to need to check the homocysteine level. And this is going to be elevated in vitamin B9 deficiency. All right. And of course, this is going to be tested, and we have our normal range for that. Supposedly, the normal value will be 5 to 15 microosmoles per liter. We have a question from Pretty. Yes, the live sessions that will be, they will remain available in the channel. So kindly check on the tab where it says live. We have all those other videos there. There's 42, I guess 42 or 41 videos already there. So you can check that out. I'll send the link through the chat box so we will be able to go back and look for those older videos that we've done in the last 41 days, I believe. All right, so those are the peripheral smear, the serum folate level, and also the homocysteine level. Those are the diagnostic tests for the folate deficiency. Now, when we are going to treat this patient, well, of course, we're going to expect that we're going to administer the vitamin B9, right? Of course. You're welcome, pretty. Vitamin B9 replacement. And this is going to vary as well according to the need of the patient and also the level of the deficiency, or let's say the severity of the problem. And when we are talking about the deficiency here, the typical dose of the folic acid will be about, let me just show it right there, folic acid. Let me clear that. The usual dose will be around 400 to 1,000 micrograms. 400 to about 1,000 micrograms, and this is going to be taken daily, per day. 400 to 1,000 micrograms per day. That's mcg right there. Please don't get confused. And also, the patient will probably have to maintain taking this medication, and they will be taking the usual 400 milligrams per day after that. Now, we will be talking about another deficiency here, which is the iron-deficiency anemia, which is basically the lack of the iron, right? And if the body lacks this substance, well, of course, there is going to be a lack of the production of the hemoglobin, all right? Lack of iron can lead to the lack of hemoglobin production. Okay, please don't be confused here. In iron deficiency anemia, there is a lack of the iron intake, possibly. That's one of the causes, right? And if there is a lack of iron in the body, then the body will not be able to produce enough hemoglobin. There will be that lack of hemoglobin. And as we know, that this is the protein in the red blood cells that is responsible to carry O2 throughout the body. And so here, when we are looking into the microscope, the red blood cells will be referred to as microcytic. They are tiny, okay? The red blood cells are tiny, and they are lacking in color. Hypochromic. So basically, they are pale. They don't have that pigment, or they lack the pigment because of the lack of iron that is responsible to produce the hemoglobin. But since there is a lack of hemoglobin, then the red blood cells will look pale. They will look very small. That's why they're called microcytic, hypochromic type of anemia. Let me write that down. Microcytic, hypochromic. Small red blood cells that are pale. Okay, and the reason for that, it's because there is a lack of the pigment, hemoglobin. Now, talking about the other description here, the appearance, like I've said, will be small. They will have that hypochromic appearance. So please don't forget that. Now, talking about the causes here, there are several causes. One of those would be the blood loss, especially if there is persistent or maybe recurrent bleeding over time. And this can deplete the iron stores in the body. Depletes iron stores. And this can happen into these patients that may have some problems like ulcers. Ulcers, probably for those who have severe form of hemorrhoids. They're bleeding every now and then. Or frequent nosebleeds. So these can contribute to the drop of the iron stores. And in some patients, of course, with those menstruating, right? So for those who have heavy menstrual period, this can also, I know the thumbnail is wrong. That was the reason that I didn't start right away, because I was confused. And so I'll talk to my boss about it, because yeah, that would really confuse people. I was like, hey, why are we doing day 2? We are doing 42nd day today. And so I did not talk right away because I might be doing something wrong. And so I kind of waited until I figured it out that the thumbnail was wrong. Anyhow, let's continue, guys. Okay. A, B, C, D. All right. Now, when we are talking about the menstrual period, or let's say the other sources of bleeding, maybe GI bleeding, this can also contribute to that. Maybe a person may have some upper GI kind of bleeding. This can also lead to the blood loss, right? And for those people that may have some deficiency in their dietary intake of iron, of course, or let's say if there is an increase in the need to take in iron during those years, especially for those infants or let's say toddlers, or for those pregnant women, there is an increased requirement in taking in iron. Okay, so please take note of these age groups: infants, toddlers, adolescents, and also pregnant women. They are prone to developing the iron deficiency anemia. Okay. All right. Now, guys, we're going to talk about the diagnosis here. How is the iron deficiency diagnosed? Well, of course, we're going to have to, what do you call this? Take a look into the iron studies. And this is going to help in the diagnosis of the IDA, iron deficiency anemia. So when we're looking into the iron studies, one of those will be a decrease in the serum ferritin. Okay, again, the ferritin, which is a component of that diagnostic test, will be decreased. Normally, the ferritin level will be around this range, about 12 to 300 nanograms per ml, and this is for the men. However, for the women, the value will be about 12 to 150 nanograms per ml for women. Okay, so please take note of that variation between the ranges. Again, the ferritin level will be decreased in this type of anemia. All right. Now, another testing that will be under the iron studies will be the increased total iron binding capacity transferase level. So what is this? This is going to measure how much transferrin or protein that can transport the iron. Let me write that down. It measures transferrin that is available in the blood. And the normal range for the TIBC basically is about 240 to 450 micrograms per DL. You don't have to memorize this one. It's good to know. And also, if there is elevation or if there is increase greater than 250 micrograms per ml, then this is suggesting that there is lack of iron. Okay, so if it's gonna say like increasing TIBC, transferrin levels, it simply means that the patient has a lack of iron. Now, talking about the decreased transferrin, okay, transferrin saturation, let me get rid of the G. That's only transferrin. There's no G. Decreased transferrin saturation. So what does that mean? Basically, the normal range here, our reference range, will be about 20% to 50%. If there is going to be a reduction of less than 20%, then of course there is that problem already. There is a problem in the iron level in the body if there is decreased saturation. Another is the decreased serum level itself. The iron level is decreased, and so if the number is less than 60, 60 to 170 micrograms per DL. So anything below 60 in the serum level of the iron, then this will help in the diagnosis of the IDA. Okay. Now, there's also the peripheral smear, which will also help in detecting. It will show the appearance of the red blood cells and the microscope. And so here, again, the size of the red blood cells will be smaller and the pigmentation will be less. So that's why they're called microcytic hypochromic type of anemia. Another diagnostic test here is the bone marrow biopsy, which is going to be like more of an invasive, but is less performed. Because the other diagnostic test will be enough to determine the iron deficiency anemia. But if in case the person will need to have this kind of invasive testing, it will show lack of iron stores in the bone marrow. Again, the bone marrow biopsy is not going to be a routine diagnostic test. It will only be done if there is really a need to determine the lack of the iron stores, which will be in the bone marrow. So it can reveal this. Now, another testing that will help in the diagnosis is probably the testing for the GI bleed. And so if the medical provider is suspecting that, so there will be the guaiac testing, positive guaiac test, or the hemocolt, in order to look for those tiny bleeding inside the GI tract, or maybe the colonoscopy, which is an invasive procedure that will involve the insertion of the endoscopic tube into the lower GI tract to identify the source of the bleeding, or maybe to find out if there is some form of colon cancer in the patient. Okay, colonoscopy to detect GI bleed and also to detect cancer in the bowel. Okay, please don't forget about the colonoscopy and the guaiac testing. So how is this iron deficiency treated? Well, we know that the popular replacement here is through the oral route, right? So this is going to involve the use of the ferrous sulfate, which is the first line treatment. And of course, in the form of the ferrous sulfate. Ferrous sulfate tablets. Okay. Now, I want you to recall the common side effects of the iron oral tablet. Do you still remember? The side effects are the following: constipation and nausea. These are expected, right? There's also some stomach discomfort. So these are side effects that we can actually manage, right? So if the patient has constipation, then we can encourage them to increase their intake of fiber in the diet. If they have nausea when they are taking the tablet, then they possibly can take with some orange juice, or basically with some amount of food, just a little bit. And we're also going to have to expect the administration of the parenteral type of iron, which is going to be indicated when the IDA is so severe. Okay, so if the person is not able to tolerate the oral form of the iron supplement, then they can benefit with the IV, or let's say IM administration of the iron. Okay, and this is also indicated for those persons that may not have gut absorption of the iron. Now, another intervention that can be done to them is the blood transfusion. However, this is only reserved for severe anemia. Let's say the person may be so symptomatic, okay? They probably would have shortness of breath because of the lack of hemoglobin, and they need to get this replacement of red blood cells through the blood transfusion. Again, the blood transfusion is not routine. It's only going to be reserved for those patients with severe type of anemia. Okay. And most often it is going to be avoided unless it is absolutely necessary, because it has some complications as well. Could be incompatibilities, maybe adverse reactions that can be late, or it could be early complications, or maybe early reactions. And in some few days, maybe the patient will develop those reactions. So again, the blood transfusion will be reserved for those severe form of anemia. Now, guys, we are going to talk about the nursing management about the iron deficiency anemia. So first things first, we definitely need to do our thorough assessment, and we're going to have to thoroughly check for their signs and symptoms. If they are fatigued, weak, if they have pale skin, shortness of breath, palpitations, those are important manifestations that we need to assess, guys. Again, those signs and symptoms are the following: fatigue, weakness. There's also SOB and palpitations. We need to assess them about that. Another is to assess for their nutrition. We need to obtain the detailed dietary history in order for us to know if they are not taking enough iron-rich foods. We're also going to have to assess about their menstrual history. If they are in that particular age, then we need to assess for their menstruation pattern, okay? If they have possibly heavy bleeding, then we need to know that as well. Assess for heavy bleeding. We also need to assess for the use of prescription medications or maybe over-the-counter medication. And so we will know for sure if those medications are contributing to the GI bleed, or maybe those medications that may interfere with the iron absorption. Okay, let me write that down. Check meds that can potentially contribute GI bleed. So what are those meds? Like the NSAIDs, right? NSAIDs, including the aspirin, right? They can cause GI bleeding. And also for those medications that may interfere, drugs that interfere absorption, such as the tetracycline, okay? So, or let's say antacids. So make sure that we are assessing the patient for their medication use. Now, part of the care here is to make sure we are providing education and counseling to those patients that has the IDA. We want to make sure that we are educating about the intake of those rich foods, those food items that can give them enough sources of the iron, right? And so those are your red meat, poultry, fish, beans, lentils, green leafy vegetables. And we're also going to have to teach them about the oral therapy of, let's say, the iron therapy in the oral form. So we need to explain to them the importance about being compliant with taking those supplements in order for them to achieve the goal, right, of getting their iron stores replenished. Okay, and we're also going to have to teach them about the side effects that we had mentioned. And for some people that may be able to tolerate intake of iron without food, then that's a good thing, right? But for those people that may have just aversion to the iron because they just dislike the pain that they experience after they take the medication, but we can mitigate that by allowing them to take the iron tablet with some food in order to lessen GI upset. Okay, we can do that as well. Now we need to teach them about the compliance to the therapy in order that they can fully get the restoration of the iron level in their body, and so they can have some improvement in their symptoms. We also need to make sure that we are checking in with other members of the healthcare team, making some referrals, maybe with the dietitian, also to make sure that their lab values are monitored accordingly. And we need to give them some psychosocial support as well, because this is going to be a chronic problem that can really impact their daily activities and also their quality of life. Now, another nursing intervention that we can do is to help promote those preventive measures in order that they can achieve that safe level of iron in their body. So again, diet is important. Another thing is the screening, right? We need to make sure that our patients are screened for the iron deficiency anemia and of course the follow-up. So here we go, guys. Are you ready for the exercise today? We have our first question, but before that, let me take a little sip of water before the fight begins. All right, let's get ready. The scenario states, a 55-year-old female presents to the clinic with complaints of fatigue, weakness, and shortness of breath. She also mentions experiencing numbness and tingling in her hands and feet and has noticed a swollen, sore tongue. On examination, her skin appears pale and she exhibits slight jaundice. Lab results reveal hemoglobin of 9 grams per deciliter, a mean corpuscular volume of 110 femtoliters, and low serum B12 levels. Her medical history includes a diagnosis of autoimmune gastritis. So here, based on the scenario that's provided for you, I want you to complete the bow tie diagram by selecting the correct disorder. And you're going to have to supplement that with the 2 nursing findings or nursing assessment findings and 2 nursing interventions. Okay. So this is your task. You need to identify the disorder based on the scenario, and then you're going to have to supply the assessment finding here and also the 2 nursing actions. All righty. I hope that you are with me right now because I'm going to proceed this time. So, what do you think would be that disorder? Okay. Well, based on the assessment findings and also the lab values, the scenario, the identified disorder here will be what? This is going to be the cobalamin deficiency anemia or the vitamin B12 deficiency. Why? Well, of course, this is caused by the vitamin B12 deficiency, right? And there is that inability to absorb the vitamin B12 because of the lack of the intrinsic factor. Okay? And again, this is caused by the autoimmune gastritis. So I'm just going to put it right here. Actually, specifically, this is going to be the pernicious anemia. I just don't have the extra room. So this is pernicious anemia, which is a type of the vitamin B12 deficiency anemia. Okay. Now, what are we going to do for this patient? Especially, what are those assessment findings that will support the diagnosis? Or before we go to do that, let's expound the different options or the other disorders. Why it's not going to be the iron deficiency anemia? Well, because the iron deficiency anemia will present with the microcytic type, okay? There will be low MCV, okay? Supposedly, the iron deficiency anemia will have low MCV, and it will not cause the neurological symptoms such as the paresthesia. That's why this is going to be the wrong option. What about the folate deficiency anemia? Well, it can also cause the macrocytic, I should say, but it does not usually cause neurological symptoms. Macrocytic, but will not produce those neurosymptoms like in vitamin B12. Now, if you had answered the thalassemia. Basically, this is another anemia, another type of anemia. And this is a genetic informed. This is going to cause a microcytic anemia as well, but will not present with the symptoms that we are seeing in the scenario. Okay, so we are going to eliminate the thalassemia as well. Now, talking about the nursing assessment findings, what are those two assessment findings that will support the cobalamin deficiency anemia or the pernicious anemia? Well, looking into the options here, we have glossitis, tachycardia, paresthesia, bruising, splenomegaly, hepatomegaly. Well, those glossitis will be assigned to this. So there's that glossitis, which is basically the inflammation of the tongue. Okay. And this is because of the impact of the vitamin B12 on the mucosal cells. And another manifestation that will support will be the paresthesia. And this is because of the involvement of the nervous system on the vitamin B12. Okay. It is supposed to be involved in the nerve function, but because of the deficiency, our patient will end up with the numbness, tingling sensation. Now, talking about the nursing action. So what are those interventions that we can do for this patient? Well, one will be the administration of the vitamin B12. We can do that. And there's also the monitoring of the neurological status. Again, those are the nursing interventions. We can administer the vitamin B12 injections and also monitor for the neuro status of the patient, because we know that our treatment here is basically to replenish. We are going to replace the lack of vitamin B12. So this is going to be doable by the administration of the vitamin B12 injections. And of course, we're going to have to monitor for the neurological status of a patient, because it can also lead to the neurological damage. So we need to keep an eye for any worsening symptoms. Now, I forgot to explain about the different options here in the assessment findings. So what are those? Tachycardia, bruising, splenomegaly, hepatomegaly, are those going to be significant? Well, we'll take a look. For the tachycardia, well, the anemia, we know it can lead to tachycardia, right? But it's not specific to the pernicious anemia. Not specific to vitamin B12 deficiency. Okay. What about the bruising? The bruising is going to be associated with problems in the platelets, as we had talked about days ago. For the splenomegaly, they are not going to be associated with the vitamin B12 deficiency. However, this is closely associated with the hemolytic anemia. It's because the spleen will be the site of the destroyed or dead red blood cells. And if there is rapid destruction of the red blood cells, they're going to be placed into the spleen, and it will cause the enlargement, inflammation of the spleen. Now, the hepatomegaly, the enlargement of the liver, this is not going to be associated with the vitamin B12 deficiency as well. This is more indicative of liver diseases and other systemic condition. Indicates liver disease, but not vitamin B12 deficiency. Okay, so I hope that you were able to answer those. I'm not seeing any answers today, so I'm not sure what is going on with you guys. Maybe you're just snacking and eating some of the leftover of the party today. Just kidding. Now, question number 2. A 60-year-old male patient has been diagnosed with pernicious anemia. During a clinical rotation, a student nurse discusses the general characteristics of vitamin B12 deficiency with the registered nurse. The registered nurse wants to assess the student nurse's understanding about the general characteristics of pernicious anemia. And so your task here is to indicate the different statements here from 1 to 8 to indicate if it's showing understanding or, let's say, no understanding about the pernicious anemia, which is basically a cause of the vitamin B12 deficiency. So the first statement states, or it said, vitamin B12 is crucial for the conversion or converting homocysteine to methionine and methylmalonyl CoA to succinyl CoA, essential body processes. 2, you get most of your vitamin B12 from fruits and vegetables. 3, after you eat foods with vitamin B12, it binds to intrinsic factor in your stomach, which is necessary for absorption in the small intestine. 4, vitamin B12 doesn't stay in your body long, so you can become deficient within a few months without enough in your diet. 5, pernicious anemia is usually caused by not eating enough foods that contain vitamin B12. 6 statement, it's crucial to determine whether someone with megaloblastic anemia has a vitamin B12 or folate deficiency, because treating with a folate alone won't resolve neurological issues. And lastly, 7, not even the last, I should say. Number 7, despite normal blood counts, untreated vitamin B12 deficiency can lead to serious neurological symptoms and lasting damage if not treated promptly. And lastly, we have individuals post-gastrectomy or with conditions like Crohn's disease may struggle to absorb vitamin B12. So let's check out statement number 1. What do you think about that one? Well, that is going to be assigned to understanding. That statement shows that the student nurse has basic understanding about the disease process, because we know that the vitamin B12 is a cofactor in those two reactions, right? It is going to help in the conversion of the homocysteine to the methionine, right? Which is going to be needed for the DNA synthesis. Homocysteine conversion to methionine. And this is again an important step in the DNA synthesis. Don't forget that. And also other functions inside the body. And it will also convert the methylmalonyl CoA to succinyl CoA, which is important in the metabolism of the fatty acids and also the synthesis of the myelin sheets. Okay, let me add it here. I don't have enough space, but I will try. Conversion of methylmalonyl malonyl rather. Methylmalonyl CoA into the succinyl CoA. So it's very complex. So what does that mean? This is going to be important in the maintenance of the myelin synthesis. Okay? And again, we're talking about the central nervous system here. And if there is that low conversion, and again, our patient will manifest the neurological manifestations. Those gait problems, they're going to end up with peripheral neuropathy. Their sensations will be affected. And so this is hallmark signs of the vitamin B12 deficiency. Okay? It is only seen in vitamin B12 deficiency, not vitamin B9. What about number 2? You get most of your vitamin B12 from fruits and vegetables. What do you think about that one? Well, it is actually wrong, because the dietary sources of vitamin B12 are actually animal products such as meat, fish, dairy, and eggs. So this is going to be NE. No understanding should be animal products. So this is wrong. Number 3, after you eat foods with vitamin B12, it binds to intrinsic factor in your stomach, which is necessary for absorption in the small intestine. Yes, that is correct. It is showing understanding. Again, the vitamin B12 in the diet will be bound to the intrinsic factor, which will help in the absorption, okay, in the small intestine, in the terminal ileum, to be specific. This is the site of absorption, terminal ileum. Now, what about number 4? Vitamin B12 doesn't stay in your body long. So you can become deficient within a few months without enough in your diet. Remember about that one. Remember that the vitamin B12 can actually be stored in the liver. So this is going to be incorrect. Doesn't stay in your body is false. It can be stored in the liver. For how long? 3 to 5 years. Yeah. I don't have enough space, guys. 3 to 5 years of storage in the liver. So this is going to be understanding. Oh, I'm sorry. No understanding, rather, because this statement, it said doesn't stay. So let me take care of that. That is going to be no understanding, because of the statement doesn't stay. No, the true statement is that the vitamin B12 can be stored in the liver for about 3 to 5 years. Now, talking about number 5, pernicious anemia is usually caused by not eating enough foods that contain vitamin B12. Let me reread that. Pernicious anemia is usually caused by not eating enough foods that contain vitamin B12. That is false. The pernicious anemia is actually caused by an autoimmune destruction of the parietal cells. It's not caused by not eating enough foods. No, it is an autoimmune disorder that can attack the parietal cells. Parietal cells are being attacked. That is why it's not going to be able to produce the intrinsic factor. Now, talking about number 6, it's crucial. What did it say? It is crucial, or it is really important, whether someone with megaloblastic anemia has a vitamin B12 or folate deficiency, because treating with folate alone won't resolve neurological issues. Let me read that again. It's crucial to determine whether someone with megaloblastic anemia has a vitamin B12 or folate deficiency, because treating with folate alone won't resolve neurological issues, which is a correct statement. Remember about what I said on the lack of vitamin B12, where it can there is a decrease in the conversion of the methylmalonyl CoA into the succinyl CoA, which is important in the maintenance of the myelin sheath in the nervous system. And so it can lead to those neurological manifestations. And so we need to first identify if the patient has B9 deficiency or if they have vitamin B12 deficiency, in order to prevent masking of the manifestations. So we're going to put number 6 as understanding. This one is no understanding. Number 7, despite normal blood counts. What does it say? Despite normal blood counts, untreated vitamin B12 deficiency can lead to serious neurological symptoms and lasting damage if not treated promptly, which is a correct statement. So this is going to be understanding. Okay. So basically, this item number 7, it emphasizes that neurological symptoms will precede the anemia in vitamin B12 deficiency. And these symptoms are those peripheral neuropathy, cognitive impairment like memory loss, especially in the older population. And they may also suffer some psychiatric disturbances, which can occur before any changes in the blood counts are observed. Again, take note of the neuro manifestations. They can occur before the blood counts are even detected. So, yeah, so by the time that the diagnosis was established late, then the patient already had the significant changes, the cognitive disorders. Now, talking about number 8 here, individuals post-gastrectomy or with conditions like Crohn's disease may struggle to absorb vitamin B12. Again, individuals post-gastrectomy with conditions like Crohn's disease may struggle to absorb vitamin B12. That is correct because of the absorption problems. So for example, if they had removal a part of the gastric tissue, this can decrease the surface area of those tissues that can produce the intrinsic factor. Or let's say if there is a problem in the terminal ileum, maybe Crohn's disease, or let's say resection of the diseased part of the bowel, this can also impair the absorption of the vitamin B12. Okay, now so in this cases, guys, especially with the vitamin B12, then we're definitely going to need to do some more investigation as far as the diagnostic testing. So again, this is going to be understanding. So how many points did you get this time? I hope that you are perfect in your scores today. So that's going to be 1, 2, 3, 4, 1, 2, 3, 4, 5, 6, 7, 8 out of 8. Hopefully so. Now let's move on to the next test question here. A 45-year-old female presents to the clinic with complaints of fatigue, weakness, and tingling sensations in her hands and feet. She reports following a strict vegetarian diet for the past 10 years and recently developed difficulty concentrating. On examination, she appears pale, with glossitis or inflamed tongue, noted on oral inspection. The question states, a 45-year-old female presents to the clinic with complaints of fatigue, weakness, and tingling sensations in her hands and feet. She reports following a strict vegetarian diet for the past 10 years and recently developed difficulty concentrating. On exam, she appears pale with glossitis, which is the inflammation of the tongue, noted on oral inspection. Now the question states, what are the potential causes of vitamin B12 deficiency in the patient? Select all that apply. Again, what are the potential causes of vitamin B12 deficiency in this patient? Select all that apply. So we have the following options. 1, chronic pancreatitis. 2, ingestion of caustic material. 3, use of histamine 2 blockers. We have the Zollinger-Ellison syndrome. 5, blind loop syndrome. 6, Crohn's disease. 7, gastrectomy. 8, vegan diet excluding animal products. 9, liver cirrhosis. And 10, folate supplementation. What do you think will be the correct answers? Okay, let me start answering the test question here. For selection number 1, or option number 1 rather, chronic pancreatitis. Well, when there is chronic pancreatitis, this is going to affect the protease activity, okay? So meaning there will be decrease in the digestion of those food items. Okay. So there's also going to be a lack of breakdown of dietary proteins. Lack of breakdown in the dietary proteins, especially for those containing the vitamin B12, right? And so with the chronic pancreatitis, there will be less absorption of those essential nutrition. And so this can lead to the vitamin B12 deficiency. And that is why this is one of our correct answers. So that is going to be one of those. What about number 2? Ingestion of the caustic material. So what is this? Ingestion of the caustic material basically is the damage. It can lead to the damage to the gastric mucosa. It can possibly lead to the atrophy of the mucosa. It can also affect the structural integrity, but it does not cause vitamin B12 absorption problem. Okay, not going to affect absorption, not affecting absorption. So we're gonna get rid of that. What about 3? Use of histamine 2 blockers. What are those medications? These are your Tagamet, cimetidine. They are going to reduce the gastric acid secretion. Okay, so this is going to reduce gastric acid secretion, especially if the person has peptic ulcer disease. They are taking this one maybe because of the esophageal reflux disease. And when this happens, there will be what we call as achlorhydria. There will be lack of the hydrochloric acid, which will decrease the breakdown of those food items that are rich in vitamin B12, supposedly. And of course, this is not going to be able to bind to the intrinsic factor because there is a lack of hydrochloric acid that's supposed to break down these food items. So this is going to be another cause. What about number 4? Zollinger-Ellison syndrome. What is this? This is going to cause excessive gastric acid production. Okay, and the reason for this is the disease itself will cause that. This is going to be caused by the tumor. This is going to produce gastrin. This is caused by the tumors. So the condition itself will basically increase the stomach acid, but will not directly lead to the vitamin B12 deficiencies unless there is going to be other factors. And so we are going to eliminate that one. What about number 5? Blind loop syndrome. Remember about what I said earlier about the blind loop syndrome, that there will be some overgrowth of the bacteria in the gut. And so this will compete with the absorption of the vitamin B12. So this is going to, the blind loop syndrome is the overgrowth of bacteria in the intestine. And the bacteria will compete for the vitamin B12. And it will decrease the availability for the absorption. Okay, so again, the person will end up with the vitamin B12 deficiency. So that is one of the answers. Again, we have 1, we have 3, and we also have number 5. What about number 6? Crohn's disease. Do you remember earlier that I mentioned about the inflammatory bowel diseases like the ulcerative colitis and Crohn's disease? They're going to affect the intestinal absorption of the nutrient or the vitamin B12. So this is going to be one contributory factor. So that is 6. What about number 7? Gastrectomy. Remember about the removal or a portion of a stomach it can also lead to the loss of the intrinsic factor production, and it can also impair the amount of the intrinsic factor that will be able to absorb the vitamin B12. So this is going to be another one. Gastrectomy, that's number 7. What about number 8? Vegan client excluding animal products. Yes, another. That will be 8. Remember that the rich sources of the vitamin B12 will be more on the animals. Okay, animals, meats, of course. 9, liver cirrhosis. What do you think about the liver cirrhosis? Do you think that it can contribute to the vitamin B12 deficiency? No. Okay. The liver cirrhosis can primarily affect the liver function and the metabolism. It can probably impact the vitamin B12 storage, but it's not going to be a very common cause of dietary deficiency. Okay, so we are going to eliminate liver cirrhosis. Again, it doesn't directly cause vitamin B12 deficiency. Now, what about number 10? Folate supplementation. We're talking about different stuff here. Folate is intended to treat the folic acid deficiency, not vitamin B12. And so it will not compete with the vitamin B12 in the absorption pathway. And so we're going to eliminate this one. So we have the following answers: 1, 3, 5, 6, 7, and 8. And how well did you do with this type of question, guys? Did you get a perfect score? All right. Moving on to the next question, number 4. A 55-year-old male presents to the ED with complaints of fatigue, difficulty walking, and tingling sensations in his hands and feet over the past few months. He reports a history of gastric bypass surgery 15 years ago and adherence to a vegetarian diet for the last 10 years. Again, the situation states, a 55-year-old male presents to the emergency department with complaints of fatigue, difficulty walking, and tingling sensation in his hands and feet over the past few months. He reports a history of gastric bypass surgery 15 years ago and adherence to a vegetarian diet for the past 10 years. Now, your task here is to review the clinical manifestations observed in this patient with suspected vitamin B12 deficiency. So I want you here to select expected or not expected for each manifestation. So here are the following clinical features. Number 1, sore tongue. 2, memory loss. 3, macrocytic anemia. 4, weight gain. 5, high-grade fever. 6, peripheral neuropathy. 7, visual disturbances. 8, pitting edema. And also we have impaired taste and smell for number 9. And 10, we have hypopigmentation of the skin. So assign these clinical manifestations to expected or not expected. All right, guys, take your pick. But I'm going to start answering this time. What about number 1, sore tongue, which is basically what we call as the stomatitis. Stomatitis, inflammation of the tongue. Remember about the vitamin B12 deficiency, it can present with the atrophic glossitis. There's going to be beefy red tongue. I hope that you still remember this. Beefy red tongue. And also there's going to be loss of the papillae. Okay. And there's going to be burning sensation in their tongue as well. So it's just not inflammation and enlargement. There is going to be burning sensation. Imagine that. Glossitis, sore tongue. This is going to be expected manifestation. What about memory loss? We are talking about what? This is on a patient with vitamin B12 deficiency. Remember about that conversion that is going to be low? It's going to affect the upper motor neuron. It's also going to affect the other nerves in the body. It can cause the peripheral neuropathy, also memory loss. Yeah, so this is going to be an expected finding in vitamin B12 deficiency. So again, there is going to be irritability. Other than the memory loss, irritability, there will be personality changes. Okay, these are going to be common in a patient with the vitamin B12 deficiency, and it will mimic dementia. Mimics or mimic dementia. So it's very important that there will be a thorough testing. There should be performance of those diagnostic tests to properly diagnose the patient. What about number 3, macrocytic anemia? What do you think about the term macrocytic anemia? Well, it is going to be expected as well. As I've said earlier, this is what we call as the megaloblastic type of anemia. The cells, the red blood cells are bigger. They are going to be larger than normal. Macrocytic. And of course, this is caused by the impaired DNA synthesis in the erythroblast. Okay? Impaired DNA caused by impaired DNA synthesis in the erythroblast. Okay, so it can lead into a malfunctioning or ineffective red blood cell production. Now, talking about the weight gain, what do you think about the weight gain, guys? Is this going to be the manifestation of the vitamin B12? Let's take a look. Weight gain. Well, the answer to that is not expected. It's not a typical signs or it's not a typical manifestation to vitamin B12 deficiency. In this type of patients with a B12 deficiency, what they're going to have will be weight loss, not weight gain. So this is weight loss. Take note of that. It's wrong. Not weight gain, but weight loss. Now, talking about the high-grade fever, well, I will immediately put that as a not expected. There's no high-grade fever involved in the vitamin B12 deficiency. But probably low-grade fever may occur in some patients with the vitamin B12 deficiencies, but high-grade fever is not a characteristic symptom. Now, talking about the peripheral neuropathy, what did I say earlier about the B12 deficiency? Yes, there will be expected tingling sensation, numbness, or let's say pain into the hands and feet. There will be abnormal sensations. What about visual disturbances? Did we mention about the visual disturbances earlier? Yes, because the vitamin B12 deficiency can also lead to optic neuropathy. Optic neuropathy. I probably did not mention this, but actually this is going to be part of it. Optic neuropathy can progress to optic atrophy. So this is going to be expected. What about number 8? Pitting edema. Is pitting edema a manifestation? No, it isn't. Okay, not typically associated with a vitamin B12 deficiency, marking that as not expected. The pitting edema can occur in severe cases of anemia or let's say heart failure, but not in this stage. What about number 9? Impaired taste and smell. What do you think about that? Well, with the vitamin B12 deficiency, it can also affect the senses of taste and also the smell because of the neurological involvement. So we're going to put that as a neurological involvement. So we will assign that to expected. Okay. Now, what about hypopigmentation of the skin? Less pigmentation. This is going to be not expected. It is not associated with the vitamin B12 deficiencies. We can only see the hypopigmentations with other dermatological conditions that could be caused by some nutritional deficiencies as well, but not in this condition. Pale skin because of the lack of the maturation of the red blood cell, but pigmentation is totally different here, virtuous lady. Yes. So not hypopigmentation, but there will be some kind of like pallor, okay? But not really the pigmentation. That's totally different. Okay, how many points did you get here, guys? How did you do, virtuous lady? What's your score in this item? How about you, Marie Flor, Darren, Mary, Charity, Ogbewi, Eunice? Very good, 9/10. What about the others? I want to know your scores today as well. All right, if you don't have anything else, so I'm gonna have to move forward with the next question. Basically, this is the same scenario, same patient, same diagnosis, but I'm using this as an evolving case. All right. So here, what your task is, you will be identifying the diagnostic test, whether they are indicated or not indicated in the diagnosis of pernicious anemia. 7/10. It's not bad, Mary Flor. Not bad. Okay. Again, your task in this test question is to identify these diagnostic tests, whether they are indicated or not indicated in the diagnosis of pernicious anemia. So the choices you have here is the peripheral blood smear, or number 2, serum vitamin B12 level, 3, serum methylmalonic acid level, 4, serum folate level. You also have the number 5, Schilling test, 6, serum intrinsic factor antibodies, and 7, serum ferritin level, and 8, gastrin acid secretion test, and 9, serum homocysteine level, and 10, bone marrow biopsy. I'm learning and I appreciate you, sir. Thank you, virtuous lady. Yes, there are so many actually tests that we don't know a lot when we are just reading into like the regular review books, and even in the textbooks, they don't really show a lot of those testing. And some of these diagnostic tests would just suddenly appear in the NCLEX. So we would be like, how did that come out? Right? And so I'm actually using the medical textbooks and also journals, articles, and also evidence-based practices, so that we will be in the current trend, not way behind. And so we are trying to help you out with the new diagnostic testing and those that are current in the healthcare setting. Okay, so what are your answers here? So we have Vinus Duran answered 8/10. That's good. Actually, that's good. Nargisa is answering 1 expected. So let's start answering number 1, peripheral blood smear. Did I said something about the peripheral blood smear earlier for the vitamin B12? Yes, as we know that it can reveal the macrocytic anemia. Yes, it will be indicated. Again, this will help determine that the patient has the megaloblastic anemia. All right. And also remember about that hypersegmented neutrophils that actually indicate an impairment of the DNA synthesis because of the malfunctioning red blood cell production. Yes. What about number 2, serum vitamin B12 level? Serum vitamin B12 level. This is also going to be indicated, as we know that there is going to be a drop in the vitamin B12 level less than 150 picograms per ml. So that is going to help the diagnosis of the vitamin B12 deficiency. All right, less than 150 picograms per ml. All right, Darren answered 1I, 2I, 6I. Okay. What about number 3, serum methylmalonic acid? So what does that mean? Is it going to be needed as one of the diagnostic tests? Correct. It is going to be indicated. Guys, it is going to be highly specific for the vitamin B12 deficiency. It will give us an idea that there is impaired metabolism due to the reduced vitamin B12 availability. So this is reflecting impaired metabolism. What about number 4, serum folate level? We are talking about the vitamin B12, guys. So do you think that serum folate level would be helpful in the diagnosis? No, it will be incorrect. It will be not indicated. It will help in the diagnosis of folate deficiency, but not distinguish between the different causes of vitamin B12 deficiency. Okay, so no. What about Schilling test? You think that the Schilling test would help? Of course, yeah, this is one of the oldest testings, but it's no longer as popular compared to in the past. And most agencies now don't have this kind of testing available in their institutions. All right, so this can actually evaluate the vitamin B12 absorption. So assesses vitamin B12 absorption. So that is indicated. Again, what is this? What are the different stages in the Schilling test? Remember, it starts with the administration of the radioactive vitamin B12, and then this patient will take that oral dose, and then there will be collection of the urine over the 24-hour periods to measure the vitamin B12 absorption. And then this will be followed by stage 2, wherein there is going to be administration of the intrinsic factor, which will be received together with the vitamin B12, and then another 24-hour urine collection will be done to check for the absorption with the intrinsic factor, and then it will be analyzed after to compare the levels of the absorption. And so that's about the Schilling test. Now, talking about the serum intrinsic factor antibodies. So what do you remember about that one? Serum intrinsic factor antibodies. Well, remember that this is going to help detect those antibodies working against the intrinsic factor. So this can also confirm the autoimmune gastritis. Detects autoimmune gastritis. So that will be indicated. Now, what about number 7, serum ferritin level? This is one of the iron studies. And I only mentioned the serum ferritin level in the iron-deficiency anemia. It will not be indicated in the vitamin B12. Okay, so not indicated here. Again, it is only applicable for the IDA, only applicable for the iron deficiency anemia. What about number 8, gastric acid secretion test? Yes, this is going to be indicated as well. This will help test the gastric acid secretion. And so for those people that may have the pernicious anemia, there is what we call as achlorhydria. There is a lack of the hydrochloric acid secretion by the stomach. So this is going to be present in pernicious anemia. Okay, so this is expected. What about the serum homocysteine level? What do you think about that one? It is also correct. It will show elevation. There is elevation of the homocysteine level. And this is again indication that there is vitamin B12 deficiency. vitamin B12 deficiency. And lastly, number 10, bone marrow biopsy. What do you think about that? This is going to be not indicated. This is only going to be useful for the diagnosis of severe vitamin B12. So we're not really gonna consider that one. Well, maybe I'm changing that one. Actually, that is indicated. So changing that to indicated, bone marrow biopsy. Bone marrow biopsy will be used to detect the severe form of the vitamin B12 deficiency, but not routinely done for the milder forms. But it will still be indicated, guys. So in general, it will be indicated. Now moving on to the next one. Number 6, a 60-year-old male client with iron-deficiency anemia is refusing to take the prescribed oral iron medication due to the nausea. The nurse should do which of the following? Select all that apply. 1, recommend the use of ginger when taking the medication. 2, ask the client to describe the nausea in detail. 3, advise the client to use stool softeners to reduce constipation. 4, offer to switch to intramuscular iron injections. 5, suggest taking the iron with orange juice. Okay, we have a select all that apply test question here for number 6. What do you think? Select all that apply. So let's take a look at number 1. Recommend the use of ginger. Yeah, when taking the medication. This is going to be one of the possible nursing actions. The ginger itself can help alleviate nausea. The nausea can be a common manifestation of taking the iron supplement orally. So this is going to be a good intervention. What about number 2? Ask the client to describe the nausea in detail. Well, we need to have that information, right? We need to we need the patient to tell us the specifics of the nausea so that we can help in determining the most effective solution. So that is 1. What about number 3? Suggesting or advise the client to use stool softeners to reduce constipation. Are we supposed to do that? Advise the client to use stool softeners to reduce constipation. Well, it might help with the constipation, but they are not typically recommended first for clients with iron deficiency anemia. What we need to do here instead is to encourage high fiber in the diet. So stool softeners will be used after the high fiber diet is not effective. So we are going to eliminate 3. What about number 4? Offer to switch to intramuscular injections. You think this would be appropriate? Well, as we know that the intramuscular injections for the iron is only reserved for those cases where there is an ineffective absorption of the medication orally, or maybe because of the possible severe side effects in the GI tract. So we are going to eliminate this one. This will not be appropriate this time. What about number 5? Suggest taking the iron with orange juice. Yes, the orange juice will help in the absorption of the iron orally, and this will be one of those effective nursing actions. We need to encourage that one. Okay, it can lessen the nausea when taken together. So this is going to be our 3rd answer. So we have selection number 1, number 2, and number 5. Let's move to the next test question here, number 7. The nurse has just admitted to a 45-year-old female client with a serum vitamin B12 concentration of 820 picograms per ml. Which lab finding should prompt the nurse to inquire about the drug or alcohol use? The question states, the nurse has just admitted a 45-year-old female client with a serum vitamin B12 concentration of 820 picograms per ml. Which lab finding should prompt the nurse to inquire about drug or alcohol use? Is it 1, total bilirubin of 0.3 milligrams per dl, 5, serum creatinine of 0.5 milligrams per dl, 3, hemoglobin of 16 grams per deciliter, or 4, folate 1.5 nanograms per ml? What do you think? And the question here is basically finding the lab finding that will prompt you as the nurse to inquire about drug or alcohol use. So you as a nurse here will suspect that maybe there is alcohol abuse that could potentially lead to the malabsorption of the medication, or it could be that the patient may be taking another medication that may compete or may prevent the absorption of the vitamin B12. So what would be that laboratory testing that you would suspect that there is a possible use of alcohol and drug, other medication? Well, the correct answer here is number 4. Okay, folate of 1.5 nanograms per ml, 3.4 nanoosmoles. Okay, let me explain. When the patient is low in their folate level, and the normal range for this, the normal value is supposed to be at 1.8 to 9 nanograms per ml. So our patient's value is way below the lower limit. And so the low folate here, alongside with the low vitamin B12 level, can suggest that there is also a folic acid deficiency, which is possibly be caused by the alcohol use, which basically will impair the absorption of the vitamin B9 and B12. So both are going to be low in this scenario, okay, because of the alcohol consumption. If we are talking about number 1, total bilirubin of 0.3 milligrams per deciliter, this is indicating normal range. For number 2, serum creatinine of 0.5, that is also it's not gonna pinpoint to the problem, because basically this is gonna, it's not associated with alcohol use. This is actually a low creatinine level, but not indicating alcohol use. Hemoglobin of 16, this is also a normal value, so it doesn't indicate any issues related to the alcohol or drug use. Okay, so our focus in this test question is basically to identify the normal ranges of our lab values so that we can identify if the malabsorption is related to the use of the alcohol, and it can potentially decrease both the folate level and also the vitamin B12 level. Let's move on to item number 8, guys. The statement says, a 35-year-old vegetarian client was referred for nutritional counseling for anemia. Which outcome indicates the client does not understand the counseling? The question states, a 35-year-old vegetarian client was referred for nutritional counseling for anemia. Which outcome indicates the client does not understand the counseling? Is it 1, adds dried fruit to cereal and baked goods? 2, 2, cooks tomato-based foods in iron pots. 3, drinks coffee or tea with meals. And 4, adds vitamin C to all meals. What do you think? Your question, Melrose, about vitamin thiamine deficiency, yes, that's also related to alcohol use because of the poor absorption. You are exactly correct. That is a good question. Yes. The thiamine deficiency is also common. Remember about the Wernicke-Korsakoff syndrome in alcoholic individuals? Yeah, that's going to be one. Very good. So what is your answer here for number 8? Virtuous Lady answered 3. So that is the correct. Same thing with Shika and Charity. That is the correct answer because the coffee and tea, they can inhibit the absorption of the non-heme iron. Drinks coffee or tea with meals, this can inhibit absorption of what? Non-heme iron. And this is going to be crucial for those vegetarian. We are talking about a patient that is vegetarian. All right? If they are only relying into the plant-based sources, yeah. This is going to be compromising their levels of the vitamin in their diet. All right. What about number 1? What is that? Adds dried fruit and cereal baked goods. What do you think about that? They're actually good sources of non-heme iron. Dried fruits, dried fruit to the cereal. Yes, that is a good practice. Where's my pen was in reverse. What about number 2? Cooks tomato-based foods in iron pots. This can also enhance the iron absorption. So we are going to include that as one of the correct answers. And 4, adds vitamin C to all meals. So this question is kind of like vague, right? It's just asking about anemia. But we will know for sure really is like, hey, what is this? This is a patient that is a vegetarian. And so they're going to be prone to developing any kind of anemia here, especially that they're not consuming any animal-based food sources. Now, what about number 4? Adds vitamin C to all meals. So for those like used to doing this is going to enhance the absorption of the non-heme iron from plant-based sources as well, adding vitamin C during their meal. So there's going to be a corresponding doses that will not exceed the required dietary allowance as well. Okay, let's move on to number 9. A 50-year-old client is admitted after falling downstairs at home. With a history of gastric stapling 2 years ago, the client mentions being clumsy and tripping frequently. The nurse should ask which questions. Select all that, apply. Select all that, apply. The patient is admitted after falling downstairs at home. So what would be that question? Or questions rather, because this is a select all that apply. First question, are you feeling any tingling or numbness? What do you think? Are you feeling any numbness or tingling in your arms or legs? 2, how much vitamin B12 do you usually take? 3, have you been feeling down or sad lately? Okay. And 4, do you feel secure and safe in your current living environment? And we have 5, are you consuming enough iron through your diet? So I want you to take a look into your SATA. I'll wait. 1, 2, 3, 5. What do you think, guys? What do you think are the correct answers? I'm seeing Darren answered 145, Masibiara 135, Nargiza 4, Virtuous Lady answered 1345. Tripping. They're actually falling. They're actually not able to stand on their feet at this point, especially in the stairwell, or let's say the stairs. They're falling. Let's just put it that way. They're actually falling. So we have Charity answered 125, 1235. Venus Ridaran answered 1235. Halimatu answered 145. Marie Flor answered 134. Esther 113. 135? Okay. All right. So the correct answers for this test question is the options 1, 2, 3, and 4. Okay. Again, that is 1, 2, 3, and 4. The nurse should ask the patient about the symptoms of the pernicious anemia. That is very important, guys. Okay. So make sure that you're going to do that. Ask them about the symptoms related to anemia, if they had that, okay? And then you're also going to have to ask about how much vitamin B12 do you usually take, all right? Ask them about the dose, maybe because they are not following the recommendation, and probably they are not compliant with the therapy, okay? So that simply means that they are not achieving the recommended dosing. Okay. Okay. And also what we're going to ask here is, are you feeling depressed? Okay. Because in some patients with pernicious anemia, they can also have this cognitive problem. They're going to be depressed as well. So this is important to ask. And the same thing with number 4. Do you feel safe at home? This is going to be the correct answers are 1, 2, 3, and 4. For item, what is this item again? We are on item number 9. Okay, the correct answers are 1, 2, 3, and 4. So do not neglect asking the patient about their safety at home. That is very important. Make sure that this is screened because possibly there is some form of abuse at home. We want to know that. And also, like I've said, the deficiency can lead to some cognitive disorders. So it can also lead to some kind of depression. So we need to ask our patient about their depression if they have this. And we'll ask them about the dose to find out if they are really taking the recommended dosing schedule, or maybe they are skipping the daily doses. And also we are going to ask them, are you feeling any tingling or numbness? These are the neurological manifestations that are specific to the vitamin B9 deficiency. So our answers are 1, 2, 3, and 4. So we need to check for this. Feeling depressed. Okay. Depression is one sign of vitamin B12 deficiency. And this Number 2, we'll check for the compliance with the scheduled dose. If they are not getting it as required, if they are not taking it rather, then their levels of their vitamin B12 is not achieved. And 1, are you feeling any tingling sensation or numbness? These are the neuro signs and symptoms of the vitamin B12 deficiency. So we need to find out if they have those. All right, very good for those who were able to capture those one. Okay, how are you doing, guys? Are you learning with the test questions so far? Let's move on to the next item, number 10. Which conditions justify the use of the parenteral iron preparation? Select all that apply. Question number 10. Which conditions justify the use of parenteral iron preparation? Select all that apply. Is it 1, chronic blood loss of 750 mL per week? Wow. Chronic blood loss of 750 mL per week. That is insane. 2, celiac disease with a concurrent anemia. 3, history of chronic alcohol use or alcohol abuse. 4, intestinal disorders causing impaired iron absorption. 5, megaloblastic anemia. I repeat, the question states, which conditions justify the use of parenteral preparation? So was this parenteral iron preparation? I can barely see it from here. I need some eye checkups. So we have an answer here from Charity. No, not Charity, rather. Mary Flor answered 1, 2, 4, 5. We are talking about iron, not about vitamin B12 or vitamin B9. Be careful with your answer. We're not talking about vitamin B9 or B12 malabsorption. We're talking about iron. So what would be those conditions that can justify the use of the IM or let's say IV iron preparations? Let's talk. Number 1, chronic blood loss of 750 mL per week. Yeah, that is a lot. I don't know a person of anybody that I know of that has blood loss of 750 mL per week. That is like almost a liter. Wow. So with this patient that has massive loss of blood, they definitely need to have the parenteral iron to effectively restore their iron levels faster. Okay, so they need this really bad. They need to have the parenteral route, could be IV or could be the IM. Number 2, celiac disease with concurrent anemia. Well, we know earlier about the celiac disease, right? Conditions like this one can impair the iron absorption to it can impair the absorption of iron due to the gastrointestinal damage, right? And so what do you think? It can also qualify them to receive the parenteral iron supplement, okay? Because of the malabsorption syndrome. Do you recall about the celiac disease? It can cause thickening, necrosis of the intestinal lining, and so it can impair the absorption of those important iron, right? Nutrition. And so this is going to qualify them. So let me just put here the answers. We have 1, 2. What about 3? History of chronic alcohol use. History of alcohol chronic use. Do you think that this can qualify? We know that alcohol use, especially chronic use, can lead to the nutritional deficiencies, but it's not going to be typically indicated due to the alcoholism. Okay, it's not. So sorry about the alcoholics. They're doing it deliberately, but it's not going to be, it's not going to justify the reasoning why they should be getting the iron via IV. Nope. 4, intestinal disorders causing impaired absorption. What do you think about that one? Intestinal disorders, for example, if the patient may have the inflammatory bowel disease, the Crohn's, the ulcerative colitis, then there's going to be poor absorption of the iron from the food sources. So they're going to be able to get that parenteral route as well. Okay, so that's 3. What about 5? I'm sorry, 4 rather. Let me correct that. I got so distracted. So that will be 4. Now, what about number 5? Megaloblastic anemia. Megaloblastic anemia, do you remember what that is? This is the type of anemia that is primarily associated with the deficiencies in the vitamin B12 or the folate rather than the iron deficiency. And so this is not going to be related to that. So parenteral nutrition, or parenteral iron rather, I'm sorry. So the parenteral iron preparation is not typically required unless there is concurrent iron deficiency. So we are going to eliminate this one. So the correct answers will be 1, 2, and 4. Very good, Virtuous Lady and Mary Akugri. We have, who else? Narjisa, but you answered 4. Okay. Alrighty. We have Masabiata 145. I don't know if this answer is applicable to question number 8. But you know what your scores are, right? I hope that you're tracking your scores. Now let's move forward to number 11. A 45-year-old patient who has been taking extra doses of oral ferrous sulfate reports symptoms of abdominal pain and lethargy. The patient's serum iron level is 560 micrograms per deciliter. The nurse expects the provider to order 1, discontinuing the ferrous sulfate and rechecking the iron level in 1 month. 2, gastric lavage and treatment for the acidosis and the shock. 3, giving oral another tongue twister. Giving oral deferasirox, or what we call as X-Jade. And 4, giving parenteral deferoxamine. Yeah, that's easier. Disferal. Again, the choices are discontinuing the ferrous sulfate and rechecking the iron level in 1 month. 2, gastric lavage and treatment for acidosis and shock. 3, giving oral deferasirox. I think I got it this time. And 4, giving parenteral deferoxamine or the Desferal. What is your answer? Guys, take a look into the patient's iron level in micrograms per deciliter. I'll wait for your answers. Chika answered 1, which is discontinuing the ferrous sulfate and rechecking the iron level in 1 month. Guys, I want you to identify if this is an overdose or is this toxicity. Okay, recall the value of the iron. And our iron level for this patient is 560. Overdose. Okay. But look at the situation here, guys. The patient who has been taking extra doses of oral ferrous sulfate. So they're still able to report, right? They are suffering from the abdominal and lethargy. So basically they are getting way more than they're supposed to. Okay. Iron, 560 micrograms per deciliters. Okay. It's very high. Normally, the level is 60 to 170 micrograms. Okay. That is the normal range. Micrograms per deciliter. So our patient's value is skyrocketing. 560. So the correct answer here, guys, is number 4. That is to give parenteral deferoxamine desferal. So the patient has been taking this for a long time. So they just have the buildup of the iron inside the body. And this is already toxic. This is toxic. And a good thing that they're able to survive, right? They not really end up with other manifestations, but they can still lead to that complication. But at this point, they were still able to report about the amount that they were taking. And so what we're going to get ready here is to anticipate the administration of the deferoxamine, which is a chelating agent. And this is going to remove excess iron quickly. This will quickly remove the iron in the body. So the deferoxamine is what we call as the chelating agent. Right? It removes excess iron quickly. Why not number 1? I know number 1 is kind of, yeah, it sounds good to discontinue. Yes, of course, we need to discontinue, right? But the half of the statement stated rechecking the iron level in 1 month, this is a little bit kind of like far apart from the date that you spoke with the patient. We need to have that level done right now. Okay, so delaying the laboratory will actually also delay the treatment. We need to make sure we are assessing this patient's iron level right now, not after 1 month. Okay, so this is wrong. This is correct. What about number 2? Gastric lavage and treatment for acidosis and shock. What do you think? Well, this is only effective if the iron was ingested very recently. Okay, let me take note of that. Only effective if iron was ingested recently. So we can still remove that through the insertion of the nasogastric tube, and then we're going to have to allow to drain or wash the stomach of the patient, gastric lavage, and drain it in order to remove the iron tablets. We can do that, but only if ingested recently. Okay, it's not going to be effective for this patient that has been taking it for a while. 560. It's an accumulative dose or accumulative level of excessive dosing. Okay. Now, what about number 3? Giving oral deferasirox. I got it this time as well. Oral deferasirox, which is the XJade. So this is also an iron chelating agent, but this is used for chronic iron overload conditions. But this is indicated for those patients that are taking blood transfusions repeatedly. Okay, so this is indicated for patients with repetitive blood transfusions that can lead to high iron level. Okay, again, the XJade is also a chelating agent, but this is more effective in those patients that have been getting the blood transfusion frequently, which can lead to iron overload, but will not be effective in treating this patient that has ingested the iron pills for a long time. So definitely different indications. Okay, so our correct answer here will be number 4 option. Okay, how are you today? Are you learning from this question number 11 between the deferoxamine and the XJade? I hope so. Let's move on to the next option, next item, which is number 12. A 55-year-old patient with severe vitamin deficiency, vitamin B12 rather, presents with hypoxia, anemia, numbness of hands and feet, and oral stomatitis. The nurse expects the prescriber to order 1. Intramuscular cyanocobalamin and folic acid. 2. Intramuscular cyanocobalamin and antibiotics. 3. Per orum cyanocobalamin and folic acid. And 4. Per orum cyanocobalamin and blood transfusions. The situation is a 55-year-old patient with severe vitamin B12 deficiency presents with hypoxia, anemia, numbness of hands and feet, and oral stomatitis. The nurse expects the prescriber to order. Is it 1, 2, 3, and 4? Take your pick, guys. Vitamin B12 deficiency. This is the problem. And there is now hypoxia, anemia, numbness of hands and feet, and oral stomatitis. Yeah, I'm actually debating this kind of question myself. But looking into the manifestation, hypoxia, yeah, right? 1 or 4. If I am going to answer this myself, I would actually answer number 4, which is the correct answer, because there is already the hypoxia. This is already a compromise in the oxygenation. There is now probably a hemodynamic instability. Okay, so when there is already the occurrence wherein the body will be needing severely that oxygen, which is basically the hypoxia, you got to treat that one. And this is going to be a form of the severe form of anemia. You need to have blood transfusions along with the cyanocobalamin, what do you call this? PO. I know this is kind of like IM-PO. But as we know that the cyanocobalamin already is, it's going to take a while to be absorbed anyway. But at this point, when the patient has hypoxia, our circulation is impaired. So we need to address that by the administration of the blood transfusion. So if I am going to revise this question, I probably would recommend IM here, but it is what it is. So the correct answer here, guys, is number 4. Even if the statement, even if it stated PO, but here we really need to treat the hypoxia, and this is going to require the blood transfusion. The IM cyanocobalamin will not be able to treat the hypoxia. It will take a while for this to improve the red blood cell maturation. So it's not gonna have an immediate effect. So we're gonna definitely need to administer the blood transfusion. Okay, do you understand the logic here about the need for the blood transfusion this time because of the hypoxia? I hope so, but that is the rationale. Okay, number 13. A 65-year-old patient with moderate vitamin B12 deficiency is found to have a low plasma B12 levels and a positive Schilling test indicating vitamin B12 malabsorption. The provider prescribes oral cyanocobalamin 500 micrograms daily. The nurse should contact the provider to 1. Hi, just joined, have been here since. Okay, welcome back, AG Ike. All right. Okay, let me reread the question. A 65-year-old patient with moderate vitamin B12 deficiency is found to have low plasma B12 levels and a positive Schilling test indicating B12 malabsorption. The provider prescribes oral cyanocobalamin 500 micrograms daily. The nurse should contact the provider to 1. Discuss IM dosing, that is intramuscular. Just to clarify that means intramuscular. 2. Request an order for folic acid. 3. Suggest an increased dose. 4. Suggest platelet transfusion therapy. Our patient has vitamin B12 deficiency, found to have low plasma B12 levels and a positive Schilling test, basically telling us that there is malabsorption of the vitamin B12. And the doctor prescribed cyanocobalamin 500 micrograms daily. So what would be your choice? So it said the nurse should contact the provider to 1. Discuss IM dosing. 2. Request an order for folic acid. 3. Suggest an increased dose. 4. Suggest platelet transfusion. Okay. All right, let's reveal the answer this time. So if you answered number 1, discuss IM dosing, we know that the intramuscular route is effective, right? Because of the rapid absorption of the medication into the muscle and into the bloodstream. Yes, we know that. But at this point, when the patient has vitamin B12 deficiency, a higher oral dose are actually going to be sufficient, okay? Higher, even if they have malabsorption syndromes, but if the dose will be higher oral dose will actually be sufficient for the vitamin B12 malabsorption. And so what will be the expected dose here? Well, the recommendation for the dosing schedule here will actually be around what? How much of the micrograms per day? They are going to take an increasing dose, which is basically going to be about 1,000 micrograms. Micrograms to 2,000 micrograms. And this is going to be enough in treating the malabsorption syndrome, okay? So it can be treated with oral. So it's not really necessary that they should switch to the intramuscular. It will spare the patient from the extra poke, right? I don't like injections myself. No, I'm not referring to the question here, but if I'm the patient here, I would rather have the oral route rather than the IM, right? That's going to be extra poke. Actually, in some cases, it can actually reach up to 10,000. Imagine that. 10,000 micrograms per day, maximum dose. Yeah, that is possible. So for some patients, it can be 1,000 to 2,000, but to the maximum of 10,000 micrograms per day. So they can enjoy the suggestion of increasing dose, which will be 3. Okay. What about number 2? Request an order for folic acid. Well, remember, guys, that folic acid is vitamin B9. It will not address the vitamin B12 deficiency. So, will not work. It will not work because it addresses B9 deficiency, not B12. So you're going to eliminate that as well. What about 4? Suggest platelet transfusion therapy. Do we have an issue here with platelet disorder? No, we're done with that topic about the platelet disorders or coagulation. I'm over it. I'm not going to go back to those lectures. No, just kidding. But we're not going to need any platelet transfusion this time. There is no IM Schilling is diagnosed. What do you mean by IM? Intramuscular is Schilling. Well, this patient has already been diagnosed with the vitamin B12 deficiency, right? So they are already known, moderate vitamin B12. So they're already identified. But like I said, it's just not about intramuscular route or let's say subcutaneous. There is another option for that. We can increase the dose of the oral medication up to a maximum of 10,000, and this will be suffice to replace to replenish the body of the vitamin B12. So for suggest platelet transfusion therapy, it's not indicated for a vitamin B12 deficiency unless there is thrombocytopenia. Okay, so we are only gonna use this indicated only if there is severe thrombocytopenia. And we don't have that in this scenario. So it's not required. So we will eliminate that one. So our answer here is 3. Okay. Suggest an increased dose. Number 14, following a hip replacement surgery, a nurse observes a patient who has been undergoing iron replacement therapy for 2 days. The patient's stools appear black and they exhibit pallor and fatigue. Vital signs include a heart rate of 98 beats per minute, respirations at 20 breaths per minute, and a blood pressure of 100/50 mmHg. The nurse will communicate with the provider to 1. Report the possibility of gastrointestinal hemorrhage. 2. Request a hemoglobin and hematocrit assessment. 3. Seek an order for a stool guaiac test. 4. Propose administration of a hypertonic saline or hypertonic fluid bolus. What is your answer? So it said here, following hip replacement surgery. Patient has been undergoing iron replacement therapy for 2 days. The patient's stools appear black, exhibit pallor, and fatigue. Vital signs include a heart rate of 98 beats per minute, respiration 20, and blood pressure of 100/50 mmHg. The nurse will communicate with the provider to are you going to report the possibility of GI hemorrhage? Is the patient bleeding? So are you going to talk to the doctor about GI bleeding this time, or are you going to request for a hemoglobin and hematocrit assessment? Or are you going to get an order for a stool guaiac test? Or are you going to propose administration of a hypertonic fluid bolus? So be careful, guys, with your choices here. Try to eliminate those interventions that can harm the patient. Eliminate unnecessary interventions. That would be my clue for you. Eliminate unnecessary and unsafe interventions. So I want you to go back into the patient's vital signs. Are the vital signs within normal limits? Are they? If they are not, then you probably would have to do something about it, right? Are they within normal limits? Is the patient heart rate abnormal? Is the patient's respirations abnormal? Is the patient's blood pressure abnormal? So if they're abnormal, then you do something about it. But if not, then look for something else. Okay. So let's take a look on option number 1. Report possible gastrointestinal hemorrhage. Why would you do that? As we know that the patient is taking iron, it is a normal side effect. It is expected that their stool will appear black. That is an expected finding. Okay? All right. So, do you need to worry about that? Possibly not. And this is not going to indicate GI hemorrhage. Okay? BP is low. Are you sure that this is low according to the standards of the new blood pressure guidelines? Do you think that this is low? What is the blood pressure we have? 100/50? Maybe if you're referring to a regular like 100/60, but is that very low? What is the difference here, guys? 100/50, that has the pulse pressure of 50, which is basically within the normal range. Within the normal range pulse pressure. This is considered normal, okay? Yeah, you might consider this as a slightly low, but is this concerning? Will you consider this as an urgent issue? Of course not. 100/50 blood pressure? No, it's not indicating urgency. It's not even considered low in some patients. All right? So, not considered low blood pressure. Okay, remember about the mean arterial pressure and the pulse pressure? You got to calculate those. Okay, so we are going to eliminate 1, report the possibility of GI hemorrhage. It is expected that they're going to have black stool. Okay, what about 2? Request a hemoglobin and hematocrit assessment. Yes, we need to further investigate the patient's state by assessing the patient's hematocrit and hemoglobin level. We need to know that in order to rule out if there is really a hemorrhage going on, right? And of course, look into the manifestation. A GI bleed will normally end up with tachycardia. Is our patient tachycardic? No, our patient is not. Maybe the patient has some kind of pallor, which is some signs of anemia. Well, of course, that is expected right after the surgery, right? There will be blood loss. Yeah, I would consider that also as part of the GI bleed, but not really concerning. I mean, it's not just that indicator. Supposedly, if there is going to be severe iron deficiency anemia, there's also going to be fatigue. Okay, so these are expected, but in our case right now, it's not really considered tachycardia. Okay, so you don't really see here a compensation by the heart. Okay, so what we need to do is to make sure we are confirming first if there is really blood loss. If there is a significant drop in the H&H, then that is something to be worried about. H&H, significant blood loss. We need to identify that by getting the order H&H level. What about 3? Seek an order or request an order for a stool guaiac testing. Is this going to be the priority for the call? No, it isn't. It is not indicated because our patient is taking the supplement. It can make the stool's color black. Okay? Now, if you had answered number 4, proposed administration of hypertonic fluid bolus. Well, if we are going to give them hypertonic bolus, this can actually worsen the situation. So not hypertonic, we need to give the patient an isotonic solution instead. If we are worried about hypotension, do not give hypertonic solution. Give them the isotonic as prescribed. Okay? Do not give them the hypertonic because this can actually promote more fluid loss. Okay? Not hypertonic. Always remember that. If we are going to reestablish the circulation, if we are worried about the blood pressure, then use the isotonic solution to replenish the fluids in the vascular compartment. All right? So the correct answer here is going to be number 2. Request hemoglobin and hematocrit levels. So any post-op BP AGI TV, to answer that question, it will be case-to-case basis because a person can have variations in the blood pressure. For me, if I'm a small frame person, a blood pressure of 100/50 can be normal for me, right? Like I've said earlier, you gotta have to look for other sides here, not just the blood pressure. But let me check. Let me delete this section right here so I can explain further. Remember about what I said earlier about the pulse pressure, which is actually the difference of the systolic and the diastolic. So you subtract that one. So that is 50. And our patient is well within the normal range of 40 to 60 mmHg. That is the normal pulse pressure. And of course, again, it will vary from one person to the next person. So for example, if the person's blood pressure, let's say from 120/80, and then 15 minutes later, it dropped to 100/50, well, I would not consider that as a normal this time. It is a considerable drop, so I would be worried about that as well. So I'm not going to stick into just the numbers. I would have to look for the trend. If there is change in the values, if there is significant change, or a rapid drop in the blood pressure. So to answer your question, I would not consider that exactly as normal all the way. Okay, so I hope that you understand the explanation. So it will vary from time to time. You will have to assess the previous reading of the patient. Is it going to be within their range? Or is there a significant drop? So this would be your clue there. So I hope that you're understanding the explanation. We will be proceeding to question number 15. A patient has been taking Fusol for 4 weeks for iron deficiency anemia. The initial hemoglobin was 8.9 grams per deciliter. Now it's 9.7 grams per deciliter. What will the nurse ask? Again, the question states, oh, wait a second. Whoops. Let me change this question real quick because I think I did not copy the question from my Word document. So let me do that really quick. We are on 752. Let me go to that slide. 752. Wait a second. Fixing this one right now. Okay, here we go. I hope that you can read that item number 15. Question number 15. A patient has been taking Fusol for 4 weeks for iron deficiency anemia. 4 weeks, guys. look into the time frame. Taking oral iron. The initial hemoglobin was 8.9 grams per DL. Now 9.7 grams per DL. What will the nurse ask? 1. Dietary iron intake. 2. Gastrointestinal upset. 3. Tarry or black stools. 4. Prescription refill necessity. So the patient has been on Diffusol for 4 weeks now for iron deficiency anemia, but there's only an increase. How many grams difference that is? Let me use my calculator. 9.7 by 8.9. Not a lot of improvement, guys. So that's basically about only 0.8. 0.8 increase in 4 weeks. So what would be your suspicion here, guys? A patient has been taking Fusol 4 weeks for iron deficiency anemia. The initial hemoglobin was 8.9 deciliter. Now it's 9.7. So it's actually going up. But is this the expected increment in a patient that should be taking regularly for the 4 weeks? Because this is only a very slight increase. There should be more than 0.8 for this level. It's not really improving a whole lot for this patient. So what we're going to need to do here is to ask the patient for prescription refill necessity, because this will investigate further that probably they're not compliant to the therapy, because maybe they're not getting the prescription refill at the pharmacy. Because especially when we are treating the patient, if there is such a successful, we will consider this a successful replacement if there is going to be a 2 gram per deciliter increase in 1 month. In 1 month. So imagine that. This is the expected increment for this person. Supposedly, if they are taking it religiously, then we should expect more than the 9.7. So at this point, guys, this is going to you have to really think here. Is my patient taking regularly the medication, or maybe they did not get the refill for the drug? Maybe they haven't done that yet, and so they haven't been taking religiously the drug. And so this would be our question. What will the nurse ask? Prescription refill necessity. Okay? So if the hemoglobin does not increase as expected, patient should be asked about compliance. Ask about compliance to the iron replacement therapy. Okay. So that is the reason why we're going to ask them about 4. Okay. If they said that the prescription does not need to be refilled, then probably they have not been taking the medication as prescribed. Maybe they've been taking it like every other day, or maybe every other 2 days. So yeah, that's non-compliance. So this is a huge thing, especially for those needing the recommended iron supplementation. Okay, so that is very important. What about number 1? Dietary iron intake. Yeah, I know that this is important, but this is going to be successful, or this will be more about prevention but this is not going to treat the patient's low hemoglobin. This is more a prevention, but not a treatment. Okay. What about 2? Gastrointestinal upset. Well, this is a common side effect of the medication, and so not a concern. And we have ways to mitigate the stomach upset. We can recommend them to take the iron with some food or meals to lessen the stomach upset. Yeah, that's not a major concern. We can instruct them to take it with food and with orange juice as well. Okay. Tarry or black stools, this is also expected. So this is not going to call for a concern. This is an expected, so we're going to eliminate that one. So the correct answer here for number 15 is 4. Ask for the prescription if it's vitamin C. Yes, orange juice, vitamin C, those are the drinks that will facilitate the reabsorption of the oral iron supplement. Okay, so I hope that you're learning today. Again, I am inviting you to enroll to our NCLEX course at our website at nclexcoaching.com. We are encouraging you to do that so that you will be able to access to our video library with all the lectures on demand and our NCLEX questions. We have a big library of test questions there. And also, please don't forget to check the description box below for more information. If you have any questions, please ask us, okay? You're free to do that in the comment section. And if you have any questions regarding this topic today, if you need clarification, please put your comment in the comment box so that we will be able to follow up as well. And I thank you for your time. I hope that you had learned so many things today, and I will see you again tomorrow at 9 p.m. Eastern Standard Time. Okay, I'll see you again, guys. You have a great night wherever you are, or a great morning, or have a great day. You all take care. Bye-bye.